What I have tried to give you what is currently happening in Indian in India about early carcinoma of prostate, and for our US colleague it may look like they are revisiting 20 years back the situation. The more I learn about prostate cancer, the less sure I am about what I used to know about prostate cancer. 15% of male cancer are prostate cancer in developed countries compared to 4% male cancer in developing country. In India, the age-adjusted standardized rate of incidence of carcinoma of prostate per 100,000 vary between different cities. Like in Delhi, it is 11%, Mumbai 6%, Chennai 5%, Bangalore 6%, and Barsi 1.6%. But with change in lifestyle, dietary habits, increased life expectancy, rise in burden of chronic disease, it is likely the incidence of prostate cancer will show increase in future. So we might be playing a second inning in prostate cancer because all these changes are happening. Cancer prostate is the third most frequently diagnosed cancer among men in Delhi, accounting to 6.3% of all malignancy. Most patients present with advanced disease, screening and early detection being limited to few tertiary centers. This is the data published from AIIMS. The establishment of cancer registry and collection of cancer data in India is relatively recent. Existing registries cover limited geographical region. They don't cover the whole population. There is no information from the rural area. Large area of population is not yet covered. So whatever data we have is a limited data from limited area. Data on staging reported by most cancer registry are not presented according to the staging system, which is most commonly done in clinically. So paucity of population-based studies, but there are few case series and retrospective analysis which I will be showing you. What is the reason for few cases of early prostate cancer in India? This probably because infrequent detection of prostate cancer amenable to surgical cure in our country. Prostate cancer is, maybe it is less common in our country. There is no screening, so we don't know exactly what is happening. And lack of enthusiasm in detecting early prostate cancers amongst the clinician. The prevalence of histological carcinoma of prostate cancer has never been studied in Indian population. It has only been studied, this is the incidence of carcinoma of prostate, which is a low stage, high stage, intermediate stage, we have no idea. Studies in low clinical prevalence areas like Japan seems to suggest that prevalence of histological carcinoma of prostate may not be significantly different in different races. Now, there are few Indian studies which I am going to show. This is the studies published in Asian Pacific Cancer Preview. What they did, they age-adjusted prostate and female breast cancer incidence rate and proportion of cases by stage at diagnosis were compared. And data were derived from National Cancer Registry Program of India and the other Indian registry, IARC and SEER data. And the result was average annual cancer incidence rate in India ranged from 5 to 9.1 per 100,000 year of prostate cancer. And if you compare with the US, and it is 110 in white population and 180 in black population. So you can see there is so much of difference in incidence. And other important feature which came out is 85% of prostate cancer we detected at late stages in contrast to 15% in US. And you know that all early cancer prostate may not terminate into advanced cancer. So if we are seeing so much of advanced cancer, it means we are missing many more early cancer. This is another study which showed that what they studies in 922 men above the 40 years of age presenting with lower Inutex symptoms specifically attributed to prostate problem were included in the study. So basically it is opportunistic studies. Sex and trust guided biopsy and patient with abnormal DRE or PSA over 4 were done. And what they could detect, if the PSA was less than 4, then incidence of prostate cancer was 0.6%, but they did only sex and biopsy. If the PSA is 4 to 10, then it was 2.3%, 10 to 20 it is 2.5%, and over 20 to 50 it was 34%. So even if the PSA between 20 to 50, the incidence of prostate cancer in their studies is 34%. There was another question done from CMC Vellore. What they did, they have sent a questionnaire to 63 urologists of these states to assess their opinion and practice regarding the detection and treatment of early prostate cancer. Also retrospectively assess the cases of carcinoma of prostate seen in their hospital from 2001 to 2003. And you can see 69% of urologists believed in early prostate cancer detection, but only 48% attempted early detection and 41 offered these patients any curative therapy. An analysis of 153 patients revealed that at least 26 of them could have further evaluated toward curative therapy. So you can see there is a lot of less enthusiasm amongst urologists also. This is another published in last year only. What they did, they reviewed trust-guided prostate biopsy finding in 119 Indian patients with elevated serum PSA attending the urology department at tertiary care hospital. Minimum 10 core biopsy were performed in 109 patients and 12 core in 92. So patients were stratified into 3 groups with the PSA 4 to 10, 10 to 20 and more than 20. And what they found out, inflammatory pathology was the commonest, and cancer was found in group 1, 2 out of 28, 3 out of 48 in group 2 and 24 of 46 in group 3. This is the study actually was done in SGPGI. We were doing PSA, the PSA was done in our department, and we were doing biopsy whenever the PSA was more than 4, and we were not detecting many prostate cancer. So that Anil has finally put this data for last from 2000 to 2009, and it shows that there were 4,600 patients. All these patients had, you have HIS system, and the average age was around 63. The PSA, and all patients had DRE and PSA. Patient on catheter were identified. Patient with acute prostatitis, abscess, previous surgery, or those who are on 5 sulfur-reductase were excluded. The PSA more than 4 and they had biopsy. PSA, even if it is less than 4, but the DRE was suspicious, they had biopsy. All the biopsy were trust guided and 6 to 12 core biopsies were taken. Now if you see it here, you can, if the PSA was less than 4 and there was a 75% patient had PSA less than 4 and only 11% had PSA between 4 to 10, 4% between 10 to 20 and 10%, around 9% had over 20. So PSA over 40 was present only in 24.9% of the patient. Now this table is interesting. If the PSA was less than 4 and DRE was negative, then there was no cancer was detected. When the DRE was positive and this patient, 23 patient had biopsy, only 3 prostate cancer was detected. So positive predictive value was 13%. In 4 to 10, when the DRE was negative, out of 218, only 32 had cancer. So incidence was around 14%. When the DRE was positive and PSA was 4 and 10, then biopsy was done in 41 patients and 23 had cancer. So it was 56%. So if your PSA is 4 to 10 and DRE is also suspicious, incidence is very high. Between 10 to 20, if DRE was negative, out of 100 biopsy, only 26% was positive. When the DRE was positive and PSA was 10 to 20, 48% were positive. Over 20, in a DRE negative, 59% DRE positive, so 94%. So if you can see it here, out of patient who had biopsy and who had cancer prostate, out of 78403 patient had, so the diagnosis with TUR was only 1.7%. Localized carcinoma prostate was 7.3%. T3A or B was there in around 10%, and metastatic disease was around 80% of the patient. This is another interesting paper published by Dr. Kulkarni, is all the patient who he has done the radical prostatectomy in 428 consecutive patients. And now, and this is published in last year only, and you can see T1 disease was there in 41% of the patient. T2 and T2B is 32%, T2C is 25%, and T3A and T3B is 2.3%. This is the patient who has undergone radical prostatectomy. And what he concluded that up to 2002 patient approval was less due to the infrequent use of serum PSA in prostatic biopsy. So more and more cases he started doing after 2002. And distinct increase in organ confined disease in post 2002 era, 62% over 72%. Now what is the treatment offered in our country? We have in fact all the facility available. We have the radical expertise for radical prostatectomy, whether open, laparoscopic, robotic. We had all kinds of radiotherapy, external beam, brachytherapy or cyber knife. Active surveillance is also available and HIFU is also available. Active surveillance, you know. Now what is happening, probably it is my guess, because I tried to find out from different people, we are not doing more than 1,000 radical prostate in a year. So many localized cancer prostate is still being managed inadequately. This is not very uncommon, and many urologists, if they have done TURP and they came out T1C carcinoma prostate, maybe in same admission, they will do bilateral archectomy or put them on hormone and send them home. General surgeons, as soon as they see any diagnosis of carcinoma prostate, they do bilateral archectomy and send the patient home, and they think that that is enough treatment. And many general surgeon and urologists, they suggest against the radical prostatectomy because they don't believe the radical prostatectomy will cure it, or they are not doing it, so they are not advising it. Because we have patients, we have advised, they get different opinion, and then treatment is changed. And hormonal manipulation is rampant, whether it is indicated or not indicated, it is being tried number of times. And probably this is of lack of expertise in the people who do not do radical prostatectomy, as well as knowledge, lack of knowledge. That's why they are offering such treatment. But facilities for early cancer prostate is available in major cities. And radical prostatectomies are there many people who are doing. If I just put a guess, there's more than 50 urologists who are doing open radical prostatectomy. There are more than 20 who are doing robotic radical prostatectomy. Laparoscopic are only few. If I could count with my own knowledge, is approximately 5 people who are doing laparoscopic. The another thing which I have noticed it, because I have lost many patients, if you do biopsy, ask them to wait for at least 8 to 12 weeks so that inflammation is subsided, then you come for. And most of the time patient do not turn up. When you try to find out, they are already been operated. So that as soon as this patient is waiting, nobody waits and patient is immediately operated upon. Radiotherapy, we have IGRT, IMRT is readily available in many cities, and now we have a cyber knife. I think there are 3 installations of cyber knife, and brachytherapy is also done in 2-3 places. So we have facility to treat early cancer prostate. But what is the problem? Screening and early detection being limited to few tertiary centers. Despite adequate facilities for treatment, many cases present an advanced stage. Localized diseases infrequently are inadequately treated, basically because of lack of awareness and potential to decrease cancer-related mortality. Routine use of serum PSA in Indian males, we don't know, because this is still debated in Western countries whether it is required, not required, but it is still being done. Low incidence of prostate, we are not sure whether incidence of prostate cancer is low or we are not detecting it, but we believe that incidence is low. Doubtful value of screening even in population with high incidence of prostate cancer. So we don't know whether screening is required in our country, but at least opportunistic screening should be offered. Those patients who come to us and have lower index symptoms should have PSA. So there is an opportunity to cure them if they have cancer prostate. But we also need support from the government. We need more epidemiological studies that could be conducted to deepen our understanding. Enhancing data on staging, the Indian Cancer Registry could widen the scope of collaborative cross-national research. We need support of NGO to create awareness in general population. and all practicing urologists need to offer at least appropriate treatment. So it is very important what Whitmore said, is cure necessary in those in whom it may be possible, or is cure possible in those in whom it is necessary. One may not be convinced about the benefit of radical therapy, but he has to learn more and educate himself to know what is right treatment to offer. It is wrong to assume that early prostate cancer does not exist in our practice, and there are more people making living from prostate cancer than there are men dying from it, and I am also one of them. Thank you very much.